Hello everyone, Assalamu alaikum. Am I audible to everyone? Please let me know.
Yes, doctor, we can hear you.
Yes.
Okay, thank you. So welcome to everyone in this session today. Today our session is on abdomen, and we will cover 7 content from abdomen today. It is very important topics for MRCS actually. So do you have any question from our previous class? Please let me know. Okay, so everyone is silent. I want to start for today. You can ask questions anytime, okay? You are welcome anytime for asking question. So now I am starting for today. First, our topic, our content is anterior abdominal wall. From anterior abdominal wall, in exam, you are asked about the anterior abdominal wall muscles. It's sometimes they ask about origin, insertion, action, nerve supply. So you have to know the muscles of anterior abdominal wall in detail. So let's start. First of all, see the image. See the image here, external oblique muscle. Our first muscle, we will study that external oblique muscle. External oblique muscle's origin is outer surface of lower 8 ribs. Lower 8 ribs means 5 to 12 ribs. See this image, 5 to 12 ribs. Okay, outer surface of these ribs, our external oblique muscle will origin. Then it will insert at linea alba and pubic tubercle. This is linea alba. And this is here, pubic tubercle. It is not seen in this image. You can see here, pubic tubercle. See, pubic tubercle. First, we will study some important structures so that we can understand easily when we will study the origin and insertion, okay? So see this image, we will recapitulate. We all know about these things, but we should recapitulate again. Iliac crest is this area, anterior superior iliac spine. This is anterior inferior iliac spine. But for our study, we need anterior superior iliac spine. Then pubic tubercle in this area, and we need pubic symphysis from this image, okay? And 12 rib and 5 to 12 rib, we all know about that. Now come to what is linea alba. It is not asked in your exam, but we should know about linea alba. Linea alba is a fibrous band in the midline of the anterior abdominal wall. It is a fibrous band. How it is formed? It is formed by the fusion of the anterior abdominal muscles. Okay. So what's its importance? Its importance, it joins the right and left abdominal muscles, provide strength and support to the anterior abdominal wall, and it is an important landmark for the midline surgical incision. So our linea alba, this is linea alba, this midline fibrous band. Okay. So just for summary, external oblique muscle origin is from outer surface of the lower 8 rib, 5th to 12. It insert into linea alba and pubic tubercle. Linea alba and pubic tubercle. What's its nerve supply? Anterior rami of T7 to T12. What's its action? Focus on it because external oblique muscle and internal oblique muscle action, sometimes it mixed up, and we sometimes we forgot about it. So here in action, it compresses abdomen and flex trunk. It is common for both external oblique and internal oblique, and these things is important. It rotates our body to the opposite side. Focus on this word, opposite side. It rotates to our body to the opposite side. This is sometimes we may do wrong, okay? And the tips is here, how we can recognize the external oblique muscle. We should see the direction of the fiber of external oblique, internal oblique, transverse abdominis. If we recognize the fiber direction, we can recognize the muscle in cadaveric image. So see this image in this diagram. This is like inframedial direction. If I use analogy in here, we can use it like hands in pocket, okay? Hands in pocket. It is like hands in pocket direction. So it is theoretically it is inframedial or downward and towards the midline. It is asked in exam previously, okay? So it is important. You just can recognize the fibers like using hands in pocket mnemonic. Now come to the next muscle, internal oblique muscle. To know the origin of internal oblique muscle, you have to know the thoracolumbar fascia. Where is thoracolumbar fascia? In posterior part of us, this area is thoracolumbar fascia. Okay, this area. This area is thoracolumbar fascia, and internal oblique muscle. One of our origin point is from thoracolumbar fascia. From here, internal oblique muscle origin. So come to this image. First of all, we will study this external oblique. We have already studied external oblique muscle. Then come to the internal oblique. See its fiber direction like this. Okay. So if I use analogy here, we can use that it is prayer position. See this prayer position. Internal oblique muscle fiber is prayer position, or theoretically it is superomedial, upward and towards the midline. Okay, this is important, and you can use the analogy to remember this is prayer position. So internal oblique muscle fiber we can recognize like this prayer position. Okay, like this. Now come to its origin and insertion. Internal oblique muscle origin are thoracolumbar fascia, iliac crest. I have shown you inguinal ligament lateral to from lateral to third part. Okay, so here iliac crest and inguinal ligament here and thoracolumbar fascia. Then it insert into linea alba, pubic crest, and pectineal line. Okay, this is pubic crest, and here pectineal line. Here it insert. And the nerve supply from anterior rami of T7 to T12, and plus here one nerve extra L1. Its action is compress abdomen, flex trunk. It's common for both external oblique and internal oblique, and its action here, it rotate our body to the same side. External oblique rotate our body to opposite side, and internal oblique is rotating our body to the same side. Don't forget it, okay? Now come to the transverse abdominis muscles. Its name is like transverse, so its fiber direction will be transverse. So we can just use an analogy like it is belt or waistband direction straight across the abdomen. Where is here transverse abdominis muscle? Here we can get this transverse. See, this is like transverse direction. So its origin insertion like internal oblique, thoracolumbar fascia, iliac crest, inguinal ligament, lateral 1/3, and costal cartilage of ribs 7 to 12. Okay, and it insert again into linea alba and pubic crest. You have to remember this. Its nerve supply is same as internal oblique, and its action is compressing abdominal content. It is compressing our abdominal content. Next, our muscle is rectus abdominis muscle. See, first rectus abdominis muscle. Its direction is like upward downward. Okay.
ম্যাম ক্যামেরা মেবি বন্ধ আছে।
আমাকে মানে স্ক্রিন দেখা যাচ্ছে না?
স্ক্রিন দেখা যাচ্ছে, আপনাকে দেখা যাচ্ছে না।
আচ্ছা, ওকে।
ওকে নাও, আপনাকে দেখা যাচ্ছে।
এখন যাচ্ছে?
এই স্ক্রিনটা শেয়ার করে দেবেন প্লিজ। হ্যাঁ, ওকে নাও।
ওকে
ওকে
ওকে,
এখন আবার বন্ধ হয়ে গেছে। আচ্ছা, সমস্যা নেই ম্যাম, কন্টিনিউ করেন।
নাও।
ওকে এখন।
Okay. So let's start again. Sorry for the inconvenience. Now come to the rectus abdominis muscle. See this area? This is rectus abdominis muscle, and we will get some tendinous insertion in rectus abdominis muscle. Okay, we have to know the importance of this tendinous insertion. First, we will go for the origin and insertion. Rectus abdominis muscle origin is from pubic crest, pubic symphysis. Okay, we know that pubic crest and pubic symphysis. From here, rectus abdominis muscle is originating, and it insert into xiphoid process. Here, xiphoid process and costal cartilage of 5 to 7 rib. Okay, its nerve supply from anterior rami of T7 to T12, and it is also compressing the abdominal content. It is flexing vertebral column, and it another action is tense abdominal wall. Okay, now come to pyramidalis. Pyramidalis is not important for MRCS. Just you go through once. It's very easy, but in exam, sometimes most frequently it is asked in exam that about external oblique, internal oblique, and rectus abdominis muscle. Okay, these are very important for exam. Now come to the summary. In summary, we won't go in detail, but we have to know the blood supply. In very recent, sometimes they are asking about blood supply. So you have to go through this blood supply. For external oblique, lower posterior intercostal and subcostal artery. Okay, and internal oblique, lower posterior intercostal, subcostal, deep circumflex iliac, and inferior epigastric artery. Transverse abdominis, internal oblique and transverse abdominis is like twin brother. Okay, most of the things here is almost same, except some point you have to find out, and you have to go through that. And about rectus abdominis, blood supply is superior and inferior epigastric. Okay, see the common thing here, inferior epigastric is commonly we are finding, and the subcostal artery and posterior intercostal, lower posterior intercostal. So if you forget in exam, just tell the common thing first. Okay, and we should know for abdomen, posterior wall muscle is not so important, but psoas major muscle origin insertion and iliacus, like iliopsoas, it is asked in exam. We will cover it in our lower limb. I won't go through this in detail right now. Just in summary, we can focus on the direction of rectus abdominis in this 4 units. Rectus abdominis is upward downward, external oblique, like hands in pocket direction, internal oblique, prayer position, and transverse, it is transversely arranged. Okay, now come to the exam image. It is very much important. So come to this. First, we will study here about linea alba. Where is linea alba here? It is 11. Okay, then come to external oblique. Where is this? 6 is external oblique muscle. you have to be very careful about muscle and aponeurosis. Don't tell it as aponeurosis. You have to be careful about before telling whether it is muscle or whether it is aponeurosis. See here, 6 is muscle. Okay, but here you can find the 5. Where is here 5? Here. This is aponeurosis, external oblique aponeurosis. But in exam, mostly it is asked about external oblique muscle. So 6 is important for you. And 10 is here is internal oblique muscle. See the direction, okay? External oblique, like it is reflected, but you should imagine here it is when if it is in normal position, it will be like inferomedial. So it is external oblique muscle. And 10 is internal oblique, like if it is in normal position, then it will be like that. So it is prayer position. And 19 here is transverse abdominis muscle. So if I want to summarize, it is external oblique muscle, it is internal oblique, and it is transverse abdominis muscle. It is linea alba, and here 14 is our rectus abdominis muscle, and 18 is tendinous insertion. So we should know the topic about tendinous insertion. In exam, they may ask about the importance of tendinous insertion. When you will identify the structure, this tendinous insertion, they will ask you the next question, what's the importance? Its importance is it is dividing the muscle into segments, okay? Like it is doing the six-pack appearance. Next, it improved the strength and efficiency of muscle contraction. It is preventing bowstringing or bulging during contraction and help maintain the normal shape of the anterior abdominal wall. Okay. Then come to this structure. What is 7? 7 is ilioinguinal. When they will ask you about this structure, they will ask the next question, that what will happen if the ilioinguinal nerve is injured during appendectomy? Okay, your answer will be weakening of the conjoint tendon due to denervation damage, okay, which may contribute to the formation of a direct inguinal hernia. So if ilioinguinal nerve will damage, there why it will damage? Due to weakening of the conjoint tendon. And what will happen? Then as a consequence, direct inguinal hernia can happen, okay. And another consequence is loss of sensory innervation to the skin over lower abdomen, groin, and upper medial thigh. So it is exam question. Two consequences: if ilioinguinal nerve will damage, then conjoint tendon will be weakened, and direct inguinal hernia can occur. And there may be occur due to damage of this nerve, loss of sensory innervation to the skin over lower abdomen, groin, and upper medial thigh. Okay. Next question will be from here for this station. During appendectomy, what will be the direction of the external oblique muscle? We have already covered it. It is downward, forward, and medially or inferomedially. Okay, hands in pocket. Now come to what abdominal muscle has fiber that help close the deep inguinal ring, or the examiner can ask what abdominal muscle lies anterior to deep inguinal ring. Okay, we will study it in detail, but just know the answer. It is internal oblique muscle. When we will study the inguinal canal boundary, we will understand this topic, this concept. Okay. So we have covered this image. It is exam image and very, very important. I have marked in yellow color. Just go through this. Now come to this image. It is also important. Okay, from this you will be asked about 7, 6, 8. Before going through this structure, I want to tell tips for identifying the vessels and nerve. If you will find a vessels like you are imagine it vessels but it is branching, so it will be nerve. Okay, nerve will be branching, but most of the time you will get the main vein and artery, you won't get it branched. So I'm like, see here it is branching, so it will be nerve. And this area you will get which nerve? You will get femoral nerve. Then come to a blackish structure and come to the reddish structure. This reddish structure and this is blackish structure comparatively. Just you have to compare. Okay, in cadaveric image, this reddish structure will be artery. It is not branched like nerve, and in this structure you will get a blackish structure. It is cord like and it is blackish and it is flattened. Just you have to imagine, you won't get it um, like theoretical knowledge, but you have to imagine and you have to apply these tips and tricks when you will identify this type of structure. So this blackish structure will be vein. Which vein here? Femoral vein. And this reddish structure comparatively it is femoral artery, and this branching structure will be femoral nerve. This is very important for exam, very much important. Okay, now come to this comparatively less important. 4, it is ductus deferens. 6, 7, 19, same structure. 6 is reddish, so it is femoral artery, and 7 is branching, so it is femoral nerve. Okay, and which is what is this structure? 19 is sartorius muscle. When they will ask about identifying this 19, they will ask the next question, tell me the origin and insertion of sartorius muscle. We will cover it in our lower limb portion. Okay, it is it can come in lower limb station also. Now come to this exam image. It is umbilicus, but from here you will be asked about internal oblique muscle. This is internal oblique muscle. Okay, see the fiber direction. See the fiber direction. This is internal oblique, and here external oblique. This one was external oblique, and this one is rectus abdominis muscle. This two can ask, or these 3 can be asked in exam. Here another concept I just want to tell about scarpus fascia and campus fascia. About scarpus fascia, actually, first of all, we should know what are the layers we have to pierce during operation, in abdominal operation. So see here, first we have to pierce skin, then superficial fascia, and this superficial fascia is composed of campus and scarpus fascia. Campus fascia, it will come first. It is fatty layer, and scarpus fascia, it is membranous layers. Both are composing the superficial fascia. Then you will get 3 muscle and its aponeurosis: external oblique, internal oblique, and transverse abdominis muscle with its aponeurosis. Then what will you get? Then we will get fascia transversalis, then extraperitoneal tissue, or peritoneal fat and parietal peritoneum. So just you have to imagine these images to keep in your mind, then you can tell easily. Skin, fatty layer or superficial fascia, external, internal, transversus abdominis muscle with aponeurosis. Campus, the mnemonic here is you can remember that cushion-like structure or fatty layer. Okay, yellow soft fatty, and scarpa, it is just like sheet or membranous thing. It is just a pneumonia. Now come to the most complex topic today. I think formation of the rectus sheath. It is many of us find it is very difficult, but today I will tell you some tips and tricks. I think from today you won't find it difficult. First of all, we should know what is rectus sheath. Okay, rectus sheath, it is a sheath of which is enclosing the rectus abdominis muscle. It is a fiber sheath. It is enclosing the rectus abdominis muscle. Okay, and it is how it is formed. It is forming by sometimes three muscle, sometimes two muscle. So in general, we can tell the anterolateral abdominal wall muscles aponeurosis, not muscle. It's formed by aponeurosis. Just think and the concept, it is aponeurosis, not muscle. So the rectus sheath is formed by the aponeurosis of external oblique, internal oblique, and transverse abdominis muscle. Okay. And the thing is here, its arrangement is not same throughout its spreading. Its arrangement varies above the xiphoid process, above the arcuate line, and below the arcuate line. What is arcuate line? First of all, we have to know. See this image. Here, a semicircular marking, right? In both sides. This is arcuate line. Okay. This is arcuate line. So below this line and above this line, the arrangement of rectus sheath will be different. And in exam, you will be asked this thing, that what is the arrangement below and above the arcuate line, about the rectus sheath. Okay. So here tips is, imagine it like a jacket. Okay. So above arcuate line, your jacket, rectus abdominis muscle wears a jacket with front and back part. Both its front part and back part is present, but below arcuate line, rectus abdominis muscle jacket, only front part will remain. Okay. So anterior layer and posterior layer of rectus sheath present in above arcuate line, and all three aponeurises are anteriorly. In case of below arcuate line will be present, but posteriorly only fascia will remain. No muscle aponeurosis will be there. So it will be more clear here. Suppose I will tell about three different plane about the arrangement. Okay. Above xiphoid process, just remember 1, 0. Above, this is above xiphoid process, the arrangement of rectus sheath. And these two are above arcuate line and below arcuate line. Sorry. Above arcuate line and below arcuate line. So in case of above xiphoid process, you can get the external oblique aponeurosis as a rectus sheath. Okay, this is rectus abdominis muscle, and at the xiphoid process level, you can get only one muscle aponeurosis. It is external oblique muscle aponeurosis, not muscle. Okay, be careful. It is aponeurosis. And in case of above arcuate line, below arcuate line, in above arcuate line, you will get half and half. What is half and half here? See this, suppose it is rectus abdominis muscle. And for anterior layer, you will get external oblique muscle aponeurosis. And here, internal oblique muscle aponeurosis will be split up in two division, half and half. If I suppose it as one, then half will be anteriorly, half will be posteriorly. So in case of above arcuate line level, you will get external oblique muscle aponeurosis completely. You will get half of internal oblique muscle aponeurosis in anteriorly and half of internal oblique muscle posteriorly. And posteriorly, you will get another muscle aponeurosis. It is transverse abdominis. So this is 1.5, rectus abdominis 1.5. Okay, it is above arcuate line. And below arcuate line, this jacket has no posterior layer. All 3 muscle aponeurosis you will get anteriorly: external oblique, internal oblique, and transverse abdominis. So 3, 3, 0. This is the tips and mnemonics. Just remember this. In exam, mostly you will ask about this area: above arcuate line, below arcuate line, the arrangement. Okay. And this is our traditional image from our knitters. But most of the time when I see this image, it seems very complex to me previously. But right now it's not complex. See here, just above arcuate line, this is rectus abdominis muscle, and half and half. Okay, half external oblique and half of internal oblique, and posteriorly in transverse abdominis, and half of internal oblique and transverse abdominis. Okay, this one. That's all are aponeurosis. I'm just telling now shortly, but always these are aponeurosis, not muscle. These are aponeurosis. These are aponeurosis. And below arcuate line, these 3. See, these 3 are anteriorly situated. And posteriorly, you will get just transversalis fascia, no muscle aponeurosis. You will get just transversalis fascia, no posterior layer. 3, 0. And above arcuate, 1/2. So till now, do you have any question? Please let me know. Please respond. Okay, everyone is silent. I don't know why. Now come to the another complex topic, inguinal canal. Okay, this is also a very tricky topic, but I will tell you today a metaphor. Just in exam, you will be asked about boundaries. You will ask about the surface marking of deep inguinal ring and superficial inguinal ring. So before going to the boundary, we have to know where is deep inguinal ring and where is superficial inguinal ring. Okay, superficial inguinal ring you will just get to the anterior to pubic tubercle. Have you remembered about pubic tubercle in our first image? I think you remember. Pubic tubercle, just anterior to it, you will get superficial inguinal ring. So here in living object, 14 will be superficial inguinal ring. And this 3 will be, see, this 3 will be deep inguinal ring. So deep inguinal ring will be situated 1.5 to 2 centimeter above the midpoint of the inguinal ligament. Okay, here sometimes we do wrong. Sometimes midpoint, we mix up the midpoint of inguinal ligament or mid inguinal ligament. These 2 words which sometimes we mix up. So before that, see this image. It is a good image. This is our inguinal ligament. From where? This is our inguinal ligament, anterior superior iliac spine to pubic tubercle. So this is inguinal ligament, and its midpoint will be midpoint of inguinal ligament. And here you will get 1.5 to 2 centimeter above, you will get deep inguinal ring. Okay. And another thing, it will be needed in our clinical examination. where is femoral artery position, you have to you have to feel the pulsation of femoral artery position. So you have to know the surface marking. Mid-inguinal point. Mid-inguinal point means this from anterior superior iliac spine and this pubic symphysis. See here, this is pubic symphysis. And if you draw a line to this and midpoint of it, you will get mid-inguinal point. And this is the position of femoral artery. So don't mix up these two things. Now we need midpoint of inguinal ligament. Here we will get the deep inguinal ring. So these two are important for our exam. Now come to the boundary. Just I want to use here as a metaphor. This metaphor suppose it is a house. Okay. So roof of house should be strong. So it will here, if it is a canal, inguinal canal, then a roof will be formed by two muscle. Two muscle, which muscle? Internal oblique and transverse abdominis muscle. Okay. Then come to the anterior wall of this house. Anterior wall is comparatively less strong from the roof. So here two aponeurosis will form the anterior wall. Which aponeurosis? External oblique muscle aponeurosis and internal oblique muscle aponeurosis. Then come to the floor. Floor is formed by ligament, mainly two ligament, which inguinal ligament and lacunar ligament. And we have to add another part, external oblique aponeurosis. Don't forget about these two ligament name, okay? And our posterior wall, just here it is drawn to make understand like this posterior wall is formed by transversalis fascia and conjoint tendon. Now come to the conjoint tendon. What is conjoint tendon? I use a mnemonic here, IT. I plus T. Sorry. I means internal oblique and T means transverse abdominis muscle. These two muscles are forming the conjoint tendon. Okay. Internal oblique and transverse abdominis joint aponeurosis inserting into pubic crest and pectineal line and forming conjoint tendon. And what is the nerve supply? Nerve supply is iliohypogastric or ilioinguinal nerve. These are exam questions. So posterior wall mostly formed by conjoint tendon and a fascia, transversalis fascia. Okay. Then come to no need to tell lateral and medial wall boundary. Just tell this four. If examiner will ask further, then can tell. But this four boundary is very much important to know for exam. Okay. So we have covered. Now come to another clinical question. Direction of direct hernia and indirect hernia. Okay. This is a vast topic, but we all know about it. We don't go through in detail. Just see for direct hernia. See there. For direct hernia, the herniated part will be herniated through the superficial ring, not through the deep inguinal ring. Okay, just only through the superficial ring. And in case of direct hernia, it will be if suppose it is here, inferior epigastric artery vessels are situated, so it will be medially to inferior epigastric vessels. These two distinguishing point is very important, both for theoretical portion and for our clinical examination. So 2 point. It is go through the superficial inguinal ring, and it is the herniated part will be lateral to inferior epigastric vessels. But in case of indirect inguinal hernia, it will pass through deep inguinal ring and superficial inguinal ring both, and it will be lateral to the inferior epigastric vessels. Okay, this distinguishing point is very important. So come to the some abdominal plane. We have to know the transpyloric plane surface marking. We have to know the supracystal line, and we should know about the like here end of 9 costal cartilage where it is. Because of surface marking point, these are important. First come to the transpyloric plane, most important because it is frequently asked and it is frequently needed for our exam. Transpyloric plane. This is transpyloric. See the image first. This is transpyloric plane in at which level? L1 level. Okay. Now come to the surface marking point. A horizontal line that passes through the pylorus of the stomach. It is simple definition. And surface marking point will be at the level of L1. This is midway between the jugular notch and the pubic symphysis. So you have to find out the jugular notch and you have to find out the pubic symphysis, and you have to draw a line and find out the midpoint of this line, and through this midpoint this transpyloric plane will pass, and it crosses the tips of the 9 costal cartilage, right to left. Okay, this is most important for exam, and the vertebral level is L1. Then come to this, just if you have to know supracystal line. Okay, highest point of iliac crest through this supracystal line is passing. And subcostal plane, this subcostal plane is passing through at the level of L3, it passes through the lower edge of the 10 costal cartilage. And in tubercle of this, it is not important actually. This line is joining a common iliac vein to form the inferior vena cava. So for exam, you need to know transpyloric plane, subcostal plane, and supracostal plane. Okay. Transpyloric plane vertebral level is L1, subcostal L3, and supracostal is L4. Supracostal, it is needed. I'm telling them. Okay. Before that, I'll just go through this question. In exam, they can ask directly which structure are passing through transpyloric plane or which structure is passing through the L1 vertebral level. Okay. So here, see this image, it is good image. So through L1, our transpyloric plane is passing, right? So see here which structures are present here. You will get just focus on the name transpyloric. So pylorus, you will get pylorus of stomach. Then you will get fundus of gallbladder. You will get the first part of duodenum, and you will get also the end of the spinal cord at lower level of L1. We all know that L1 vertebral body already I have told. Origin of superior mesenteric artery, and origin of portal vein. I will tell you these two things later, and just need to know here that neck of pancreas. Here you will get neck of pancreas, and pylorus of stomach. I have already told. Second part of duodenum, and like here, first part of duodenum ends and second part will start. Then you will get sphincter of OD, hilum of each kidney, duodenojejunal flexure, fundus of gallbladder, tips of 9 costal cartilage. Actually, this question is not asked directly. You will ask, sometimes they will give this type will ask Most of the time they will give this image at L1 level and ask the structures from here. So from here, see 5. This is pyloric antrum. First, you have to know the vertebral body L1. 19 L1 body, and then here see it is chorda equina because spinal cord ends here. So you will get chorda equina here. Now come to the 5 pyloric antrum. This is pyloric antrum, and then come to this 15. Where is 15? This is 15. 15 is left kidney, and this is right kidney. This is left kidney. This is right kidney, and you will be asked about left liver. 40 is left. It is left lobe of liver. It is right lobe of liver. Then come to the 37 right lobe of liver. Okay. Where is aorta here? In front of vertebra, 22 is aorta. And from here, 17, this is 17 beside the vertebral body. This was major muscle. It is important. Then 13 is not important, but you should know 13 is electrospiny and 14 is quadratus lumborum. Quadratus, these are posterior abdominal wall muscle. So from here, this structure is important and it is commonly asked in exam. So you have to know this concept. Now come to the abdominal aorta branches. And what is the surface marking of abdominal aorta? You should know. From abdominal aorta, they may ask you about the paired branches and unpaired branches. Okay, here 3 unpaired branches. This is important. See, celiac trunk, superior mesenteric artery, and inferior mesenteric artery. Okay, these are single branch, and another one. This is median sacral artery. These 4 branches are single. All branches are paired. So mostly in exam they are asking about the single branches. So we are getting here 4 single branches. Celiac trunk, I want to mark it in image so that it is easy for you. Celiac trunk, superior mesenteric artery, inferior artery, and median sacral artery, and others are paired branches. It is abdominal aorta is starting at the level of T12, and it ends at L4 level. These sentences are important for exam. Just go through the other branches. You know that I won't go into these details today. You have to know the surface marking of abdominal aorta. Okay. For this, just focus on this image. It is deferred process, right? So, and this is umbilicus. Remember these 2 points. Our proximal or upper point will be just left of the midline. If it is midline, just left of the midline, immediate below the diphisternal joint. Okay, this is diphisternal joint. This is deferred process. So just below the diphisternal joint, you will get the proximal point of abdominal aorta origin, and its vertebral level is T12. This is important, so be careful. And the distal point will be 2.5 centimeter below the umbilicus, slightly to the left. See here, our abdominal aorta is situated at the left of our body. So distal point will be also to the left, 2.5 centimeter below the umbilicus and slightly left of the midline. And what is the vertebral level here? L4. Now you have to join this 2 point by 2 parallel vertical lines, and these 2 parallel vertical lines will be 2 centimeter. This is the key words. Just I want to focus. So From T12 to L4, you will have to draw these two parallel line, vertical line, 2 centimeter apart. Then you will get the abdominal aorta. This is the surface marking of our abdominal aorta. Now, another exam question. What is the anterior relation of the abdominal aorta? See this image. I'm always telling you that anatomy is a visual subject. So always you have to imagine the new image. You have to imagine the good image for answering the question. It will be easy for you. Now come to the anterior relation of abdominal aorta. So this is our abdominal aorta, right? See here, anteriorly, pancreas is seen. Which part of pancreas is seen? It is body. Okay, you have to tell it body of pancreas. Then here in front, you will get the branches of aorta. So we will get celiac branch. We will get we will get the superior mesenteric artery, right? Then come to this. As our inferior vena cava is situated to the right of our abdominal aorta, so its left branches will be anteriorly to the abdominal aorta. So here the left renal vein, remember this, left renal vein like this will be anteriorly. Then third part of duodenum, this third part, not this two part, just third part is crossing anteriorly. And root of mesentery will be here. Then coils of small intestine will be here. So just imagine our anterior relation will be celiac and aortic plexus, pancreas and splenic vein, body of pancreas, left renal vein, third part of duodenum, root of mesentery, coils of small intestine. Okay. We have already covered surface marking of transpyloric gland. This is also exam question. So come to the another important topic from here, aneurysm. So in exam, you will be asked about the definition here. What is aneurysm? So it is abnormal localized dilatation of blood vessels. Abnormal localized dilatation. Don't miss these words. Abnormal localized dilatation of which blood vessels. What is the why I'm telling it as aneurysm? Because dilatation, here you have to know the parameter more than 1.5 times of its normal diameter. Then I can tell it is aneurysm. If normal blood vessel diameter will increase 1.5 times of its normal diameter, then I will call it aneurysm. So key point here, just remember abnormal localized dilatation of blood vessel and it is more than 1.5 times of its normal diameter. So this is important definition from here. Then sometimes they are asking about pathogenesis. Just tell in case of true aneurysm, the pathogenesis will be median cystic necrosis. Just tell these words, okay? And in case of false aneurysm, post-traumatic pathogenesis can be occur. Then another question will be, what are the causes or what are the risk factor here? Here the 4 risk factor we can tell that hypertension, which is secondary to atherosclerosis and it's also secondary to smoking. Okay, then you can tell Marfan syndrome, syphilis, bicuspid aortic valve. These are important for exam. Okay, don't miss it. See here, this beautiful image, very clear image here. Aneurysm. True aneurysm, you can get 2 types, fusiform and saccular mainly. Okay, fusiform is like this and saccular you can get like this. Sometimes they will give you radiological image also. But if you know the concept, you can answer. And this is the image of dissection, aortic dissection, and this is the image of false aneurysm. So, detecting aneurysm definition. It is separation of the layers of arterial wall with propagation of dissection proximally and distally. So here keyword separation of the layers of arteries. Okay, and it will propagate proximally and distally. So separation of the layers. Do you know do you remember the layers of artery? Mainly three layer: tunica intima, tunica media, tunica externa. Okay, and this is the lumen. So in dissection, this layer will be separated, and then dissecting aneurysm, it will propagate proximally and distally. And here, in exam complication, they will ask maybe in answer sheet of exam, they mark 3 complication. So this is hemorrhage, ascending aorta, if it is the complication of dissecting aneurysm. Okay. So if aortic dissection, if it is ruptured, then massive hemorrhage and cardiac tamponade and hemothorax will happen. Just tell hemorrhage due to rupture. Then if our ascending aorta, we have already covered the what is the branch of ascending aorta, our coronary arteries, right? So if ascending aorta will involve here, then acute MI will occur. So coronary artery involved will occur and acute MI will occur here. Then we also know that the branch of arch of aorta, like one of branches, common carotid artery, right? So if arch of aorta will involve or carotid artery involvement, then stroke will happen. These 3 complication just you tell in exam. No need to tell others. Then come to, sometimes it is confusing what is false aneurysm. Okay. So in case of false aneurysm, just see this image. In this 2 aneurysm, see, layer is not split or layer is not separated. But in case of false aneurysm, see here, blood is not between vessel wall layer. Okay. The vessel wall is actually ruptured in case of false aneurysm, and it means that all 3 layers will be broken and blood escaped completely outside the vessel. Be careful here. Outside the vessel and is trapped by surrounding tissue, not within the vessel layer or artery layer. Okay, arterial layer will be ruptured here in case of false aneurysm, and blood here you can simply tell it is hematoma. So hematoma will occur and it is trapped by surrounding tissue. But in case of true aneurysm, all 3 layers here in it will be not broken. It will be just weakened and bulge in case of true aneurysm, but will not broken. But in case of false aneurysm, it will be broken and blood will accumulate within the surrounding tissue. This is the difference between true aneurysm and false aneurysm. True aneurysm is just bulging. This is normal vessel. This is true aneurysm, like just bulging, no tear of the layers. This is true aneurysm. It can be saccular, it can be fusiform, and this is false aneurysm. It will be broken, the layers will be broken, and hematoma will form within the surrounding tissue. And this is dissection. The layer will be separated. Okay, and blood will accumulate in lumen usually. Okay, now in dissection, another information with blood will accumulate within the wall and it is between intima and media. See here, this is intima and this is media. So blood will accumulate between these 2. Just you have to know this concept. So now come to the another topic, celiac trunk. Celiac trunk, the origin, the vertebral level here is T12. Its origin vertebral level is T12. it has three main branches. We can use the mnemonic left hand side. We can use the mnemonic left hand side. Okay. Left means left gastric artery. H means hepatic artery. Here you will get common hepatic artery, and S is splenic artery. I want to see you the beautiful image. Here, see, this is celiac trunk at T12. Okay, T12. Here you will get three branches. Left gastric artery for stomach. Left is gastric artery, then you will get splenic arteries for spleen. And you will get common hepatic artery, not hepatic artery for proper in this area. You will get hepatic artery proper later. Okay, be careful. It is sometimes we do wrong here. So it is common hepatic artery, it is left gastric artery, and splenic artery. These three are main branches of celiac trunk. Then we have to know, see this image, it is also a beautiful image. This is celiac trunk, this is left gastric artery, this is splenic artery, and this is common hepatic artery. I am telling again and again, common hepatic artery, not hepatic artery proper. Now come to this image. When we'll get hepatic artery proper, this is celiac trunk. You will get left gastric artery, one branch, splenic artery, second branch, and you will get common hepatic artery, third branch. Then common hepatic artery, a branch will origin. This is gastroduodenal artery. This gastroduodenal artery will branch into superior pancreaticoduodenal artery and right gastroepicloic artery. Okay, just remember this, that common hepatic artery will branch into gastroduodenal artery. Then it will be called proper hepatic artery, and from proper hepatic artery you will get right gastric artery, and proper hepatic artery will also branch into right and left hepatic artery. Okay, and from splenic artery, here you will get short gastric artery as a branch. This is a simple diagram for understanding the celiac trunk branch. Now come to, this is very important because I want to tell you, it is out of our exam concept, but we should know what is conventional arteriogram, what is DSA or digital subtraction angiography, or what is CTA angiography. Because in exam, when examiner will ask about the picture like that and about picture like that or about picture like that, how can you distinguish which type of radiological image it is? Okay, so here this is CT angiogram. Okay, and this is conventional angiogram. Conventional angiogram, why I am telling conventional angiogram, and this is DSA, digital subtraction angiogram or angiography. Why I'm calling it as DSA. Between these two images, see here no bones, no other structure. That means no destruction here. Just I am seeing the artery and its branches. Okay, but here you can see the organ, you can see the vertebra, you can see the ribs, other structure. So in conventional angiogram, you can see this destruction. And you will see the artery also, but in DSA you can just focus the artery itself. So this is the difference, and this is CT angiogram. Okay, now I think we won't do mistake. So come to these identifying structures. First of all, I want to start from one. One is, here is celiac trunk. So we already know celiac trunk has three branches. So three is, here see, it is going to spleen. So 3, it is splenic artery. It is going upward to the stomach. So it will be left gastric artery. And it is going right to the liver. 2 is common hepatic artery. And common hepatic artery will branch upward. 5 will be proper hepatic artery. And 6 will be gastroduodenal artery. See, this is complex things here. I want to show this image again. Common hepatic artery will give proper hepatic artery and gastroduodenal artery. Okay. Then proper hepatic artery will branch right gastric artery. So here, first you will get 2 common hepatic artery, then you will get proper. 5 is proper hepatic artery, and 6 will be gastroduodenal artery. Then come to downward. This is celiac trunk. Then you will get, we have already shown the abdominal aorta branches. You will get superior mesenteric artery. This is superior mesenteric artery. Okay, 7. So this is superior. This will be here. Imagine 2 kidney. So 9 will be renal arteries. This 9 will be renal arteries. Okay. Now come to 10. This is main structure. This is abdominal aorta. And 8 here. From here, 8 is our inferior mesenteric artery. Now come to this image. I have shown you this image for this one. This is exam image. So what is it? It is conventional mesenteric angiogram. Just say mesenteric angiogram. No need to tell conventional. I am just telling for understanding. So here A will be, sorry, here A will be abdominal aorta, right? So here we'll get 2. See, this is kidney. This is kidney, right? So here I will get a artery. Here I will get a artery. So above I will get celiac trunk, right? So if it is celiac trunk, then F will be splenic artery. It is going to spleen. G will be common hepatic artery. And from common hepatic artery, we'll get J, left hepatic artery, and K, right hepatic artery. Actually, as it is angiogram, all things are not shown as a main simple diagram. So you have to keep it remember. And I is going downwards, so I will be gastroduodenal arteries. And here H, here this H is superior mesenteric artery. See here. And inferior mesenteric artery you will get from here, left. How I can know that it is superior and it is inferior? Because I can't see the origin. See, our superior mesenteric artery will give its branches to the right side or small intestine, and left, left, not left. It is inferior mesenteric artery will give branch left side to the colon. So H will be this. It is coming from upward. H will be superior mesenteric artery and L will be inferior mesenteric artery. And this B and C will be right and left common iliac artery. So alpha, right and left common iliac artery. Okay. See this DSA or digital subtraction angiogram. This is celiac trunk. This is splenic artery, this is gastric artery, left gastric artery, and this is common hepatic artery. These 2 main branch I have covered. Now come to the this downward branch. This is gastroduodenal artery, and upward you will get hepatic artery proper, and here you will get right gastric artery. You can solve it easily because I have already told things. Now come to this image. So here the cadaveric image of celiac trunk. This 2 is celiac trunk. Okay. This 2 is celiac trunk, and this upward branch is left gastric artery. This left passing branch is splenic artery. Where this one 25 is splenic artery. So, and this right sided passing vessel is common hepatic artery. So here, and here, of selector. Now come to the small branches. So from left gastric artery 11, you will get 22. As esophageal branch of left gastric artery, you will get 12. As anterior branch of left gastric artery, you will get 14 as posterior branch of left gastric artery. Okay, and here you will get 10. What is 10? 10 is hepatic artery proper. This is common hepatic artery and this is hepatic artery proper. And 24 right gastric artery. Okay, right gastric artery antral branch. I have marked the important one which are coming in exam. Just go for this. Other one is not important. Others are not important. We have already covered this summary. This simple diagram will help you to keep remember the branch. Now come to the superior mesenteric vessels. Just from here, you should know the superior mesenteric vessels branch. What is the vertebral level of its origin? It is L1. It is anterior branch of abdominal aorta, right? So its main branch is middle colic artery, right colic artery, and ileocolic artery. Start from here. Ileocolic, then right colic, then middle colic. Okay. And in case this is these are the main branch of superior mesenteric artery. Another branch are jejunal arteries, ileal arteries. These are also branch, but these two are main branch, and you should know for cadaveric image. And in case of inferior mesenteric artery, we will study it later. First here, for here, we just know middle colic, right colic, and ileocolic. I use a mnemonic here, MRI. Okay, MRI. We all know about MRI. So middle colic, right colic, ileocolic. See here, just want to show this image. You have to know this is right. Sorry. So this is middle colic artery. From here, first M, then R, right colic, then I, ileocolic, MRI. And these are the jejunal arteries, ileal arteries. These are not so important. I'm just going through this. This image is important for exam. Here, see, first of all, see the most prominent and most important structure. What is one? Where is one? This is one. One is, this is abdominal aorta. And beside this, you will get inferior vena cava, right? So 1 is aorta and 10 is inferior vena cava. Then come to this prominent structure, ureter. Okay. We will cover ureter in our next class, inshallah. Then come to this from this is pancreas, right? This is enzymatic process. This is pancreas, body, head, neck, tail, and we know that I will show you image in next class, inshallah. When we will study pancreas, then it will be more clear for you. But here, just see our superior mesenteric vessels, 13 and 29. 13 and 29, superior mesenteric artery and superior mesenteric vein. See, this is reddish structure and this is comparatively blackish. So it is superior mesenteric artery and this is superior mesenteric vein. 29 is, sorry, there is a mistake. It is not like conventional. Like here, you have to remember this is this 29 is superior mesenteric artery, and this 30 is, they are marking it as a superior mesenteric vein. Okay, be careful. So here 6 is falciform ligament. When we'll study the liver segment, then it will be more important for that segment. Just need to know here 6 is falciform ligament. We will discuss it in detail in liver topic. And this 26 here, it is splenic artery 26. Just focus on this. This is spleen, right? 25 is spleen, and this artery is going towards this organ. So 26 is spleen, and it is also seeming like tortuous. So we know that is splenic artery is tortuous. So this 26 is splenic artery, and this here one is aorta. We have already know that, and here 8 is inferior mesenteric artery. 9 is C, it is blackish, inferior mesenteric vein. And 12 is here, left gonadal vein. It is not needed here. Just keep remember 8 and 9. 9 is blackish, it is inferior mesenteric vein, and 8 is inferior mesenteric artery. So here there is a chance of mistake, this and this. It is conventional. I can use the conventional tips that blackish structure is vein and reddish structure is artery. But here we can do mistakes, so be careful. 30 is here what? Superior mesenteric vein. It is also like flattened structure. And 29 is cord-like, and cord-like structure mostly it is artery. So we can use these tips here. Now come to this superior mesenteric vessels. Okay. In case of this image, just you have to know 19. 19 is superior mesenteric vein. Okay. And superior mesenteric vein, you will get the branches 9. I look here, superior mesenteric vein. You just know the vein from here, main vein, but we have to know the artery, superior mesenteric artery, and its branches from this cadaveric image. First, we should identify the 17. Sorry, not 17. It will be superior mesenteric artery. Where here is a superior mesenteric artery. Okay, superior mesenteric artery, it is not seen here. Here we can see the 17 right colic artery. We can see the 16 middle colic artery and 9 ileocolic artery. So 16 is M, 17 is R, 9 is I. MRI, superior mesenteric arteries branches, right? This here important. It is not so much important for exam, but you have to go through this image. 11 is here ileum, and this portion we will cover when we will study appendix. Just here I want to go through once. This 4 is appendix, 3 is appendicular artery, 8 is ileocecal junction, 6 is cecum, and 5 is ascending colon. Don't worry, we will discuss it in detail when we will study appendix in our next class. Okay. This is not so important. Inferior mesenteric vessels, we have to know the main branch. This is inferior mesenteric vessels, and we will get left colic artery, sigmoid artery, and here we will get suprarenal artery. Superior rectal arteries, not suprarenal, I have told wrong. Here, superior rectal artery, these 3 main branches, left colic, sigmoid artery, and superior rectal artery. See, left colic, sigmoid artery, and superior rectal artery. And here is the another complex image. just see first where is inferior mesenteric artery here? 5. You have to identify first one. One is aorta. So below this, you will have to find here first of all 5. 5 is inferior mesenteric artery. Then which are the branches of inferior mesenteric artery? This 6 left colic artery, this 14 sigmoid arteries, and this 17 superior rectal arteries. These 3 branches. I want to see to show you this image. This is inferior mesenteric artery, and it has 3 main branches: left colic, this sigmoidal, and here you will get superior rectal artery. These 3 branches, and you will have to find out these 3 from here. Okay, and this is aorta. And 10 and 11 are renal artery and vein. This is 10 is renal artery and 11 is renal vein. This 2 is descending colon. See, this is descending colon. This 3 is greater omentum. And this is 13, you know that, right kidney. But from here, actually, you have to know the 5 inferior mesenteric artery and its branches, 3 main branches, 6, 14, and 17. Okay. Okay. Now come to the another important topic, portosystemic anastomosis. From here, just you need to know which are the anastomotic points. Okay. It is not asked in detail in exam, but you have to know the anastomotic point. First, you will get esophagus vein. You will get between esophagus vein and esophageal vein. This anastomosis, we will get it at lower esophagus. Which vessels are involved here? Left gastric vein and esophagus vein. Okay, this is most important for MRCS, and its clinical importance is esophageal varices. And you will also get this type of portosystemic anastomosis at the umbilicus, at lower rectum, at retroperitoneum, and bare area of liver. But for exam, you just need to know about this first one. At lower esophagus, you will get the anastomosis between left gastric vein and esophagus vein. Okay. If you want to know, if you want to clear this concept in detail, let me know. I will tell it in detail in our next class if you want to know it in detail. But for exam, there is no need. But I have some tips and tricks for this concept. I won't go it in detail right now. But if you want to know, let me know in comment. Okay. Now, this is all for today's class, and we will cover the next topics in our next class. Do you have any questions for till now? For time limitation, I won't go further because I wanted to complete the stomach topic, but it will take more time, so I will cover it in our next class. It is very important for MRCS, but I will cover it in our next class. Till now, do you have any question? Please let me know.
Yes, Dr. Shabnam, thank you
Yes,
so much
yeah.
for your explanation. In the anatomical pictures of the inferior mesenteric artery and superior mesenteric artery, how could we, you told that this is the next page, please?
Here?
Yes, it was the right kidney. And however, the inferior mesenteric vein is on the left side, and I have the problem to distinguish, is it the right side or left side for superior mesenteric artery and inferior mesenteric artery? Both pictures
Actually,
are
yeah,
so
this is
same.
aberrant picture. Actually, this is not the normal picture. You won't get the things here in organized way, like normal simple diagram. Okay, you have to keep remember these things, like how they are marking it here, because here most of the structure are reflected, and it is not ideal picture. And don't worry, it is not important for MRCS, but it is not coming. Don't worry. But here you have to know this. You have to identify the most prominent structure from a cadaveric image. And here, first of all, you have to search about where is abdominal aorta. And this is abdominal aorta. And this is inferior mesenteric artery, right?
Right. And could we go back to the superior mesenteric artery
Yeah,
picture
yeah,
also, same as this?
yeah, this one. This one.
There isn't any aorta, right?
Yeah, yeah. Tell.
Okay.
What's your question?
No, it's done.
Okay. Actually, here the thing is 19 is not important because it is not asked. Here you have to find out 9, 17, and 16, the branches of superior mesenteric artery. Okay. These three branches are most important from here. M, R, I. 16 is middle colic artery, 17 is right colic artery, and 9 is uh, ileocolic artery. These three things. And actually, from this image, two type of station can be formed, like the branches of superior mesenteric artery, or the structure from here, appendix, like appendicular artery, where is cecum, this type of, these two portion is important for your exam. Okay, so just
Thank
focus
you
on
so much.
this. And the positive things is, in your exam they will ask most prominent structure, which is not understood. It is not asked. Don't worry about that. They will ask, they will just ask you to identify this prominent structure to go to the further question. So when you will revise finally, just focus on this marking point. Don't go through the whole cadaveric image in your final revision. Before like 10 days of your revision, just go through the marked, I have marked those structure, just go through that one. Don't go through the complex structure. Okay, any question? So I think there is no question anymore. So I want to finish this class for today. Assalamu alaikum, everyone. Do you have any question? Hello.
ম্যাম আমাদের সেশন কি শেষ?
হ্যাঁ হ্যাঁ, আমাদের সেশন শেষ।
ওকে, থ্যাংক ইউ।
ওকে।